Ms Carey.
My lady, may I call, please, Matt Hancock?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give be the truth, the whole truth and nothing but the truth.
You meet again, Mr Hancock.
Mr Hancock, your full name, please.
Matthew John David Hancock.
I think you have in front of you a copy of your statement ending 421858, and that is the fifth statement you've made to the COVID inquiry.
Yes.
And I know you've been here and given evidence before. You were the Secretary of State between the 9th of July 2018 and the 26th of June 2021, is that correct?
That's right.
Can I ask you some background questions before we descend to the detail? Do you think now, Mr Hancock, that the stay-at-home, protect the NHS, save lives messaging struck the right balance?
Yes.
And why do you say that?
Because we needed to ensure that the public across the whole of the UK understood the importance of staying at home whenever possible in order to stop the spread of the virus. The protect the NHS element was important for two reasons. The first is that it was a motivating factor to encourage people to follow that advice because belief in the NHS and support for the NHS is one of the strongest things that holds this country together. And the second reason is because it was literally true that if we didn't stop the spread of the virus, then the NHS would be overwhelmed, by which I mean the system as a whole would have been unable to cope with the demand on it, as we'd seen in other countries like Italy.
All right, we're going to come back to...
Just pause, I'm sorry. I mean, it's really important that we all are able to focus on Mr Hancock's answers, and particularly that Mr Hancock is, and I can focus on the answers. And I'm sorry, I know how important it is to you to have photographs of your loved ones, but I'm finding it really distracting because my eye is going over to the photographs all the time. So please, could you just lower them? Be really grateful. Thank you very much. Sorry, Mr Hancock.
Thank you, my lady. Mr Hancock, we're going to come to the question of overwhelm.
Sure.
A little later, but in terms of protecting the NHS,
Yes.
Do you think now that healthcare workers were kept as safe as possible at work?
Well, it was obviously extremely difficult to keep healthcare workers as safe as possible because effectively the wards of the NHS became the front line in this deadly battle. When I visited hospitals, GP surgeries, pharmacies, as I did regularly throughout the pandemic, I saw for myself. And I did that both publicly, but also quietly in order to understand what was happening on the front line. So part of the point of the inquiry is to understand how, as a system, as a country, we can do that as best as we possibly can.
I understand that you say it was difficult, but I want to know, do you think they were, in fact, kept as safe as possible or not?
Well, in the circumstances, facing a pandemic of this scale for the first time in living memory, what I can say accurately is that I and all those around me and the team in the health system did everything we possibly could. Does that mean in a system that employs 1.4 million people in the NHS with another around 2.5 million in social care that every decision was perfect? Of course it wasn't. And part of what we're here to do is to understand how that could be done better.
Do you think now that the imposition of the visiting restrictions, which meant that some people could not be at the bedside of a dying relative or could not have their partner with them in childbirth, were too strict?
I think that we were balancing incredibly difficult considerations on both sides. I think on balance, we got those broadly right across the pandemic, but I entirely understand and feel the very strong arguments on both sides. On the one hand, protecting lives and ensuring people, as many people as possible, could survive the pandemic, and on the other side, taking into account the deep emotional considerations that were important. And as you can see in the paperwork, I engaged with these issues all the way through. Where I think we got it wrong, for instance, was the way that the funeral guidance was applied on the ground. It wasn't as had been intended. But of course, funerals are places where people gather and are deeply emotional, and people come together, and that was also the thing that was driving the spread of the virus. So these were very difficult considerations, and broadly, on balance, I think they were about right. But we can go through every single decision, and you could easily make an argument one way or the other.
Do you consider that entering the pandemic with low ICU bed numbers and high bed occupancy meant that hospitals had to surge all the more and put them all the more under strain?
Yes, of course.
Do you think now that the decision to suspend all non-urgent elective care was the right one?
Yes.
I asked those questions at the outset, Mr. Hancock, because we're going to look at some of them in more detail, but I thought it might be helpful just to see where you stand now, some years on from the pandemic.
Yeah.
Can I ask you this, though, before we descend to that detail?
Yeah.
What did you understand it would look like if the NHS were overwhelmed?
That people wouldn't be able to get any treatment at all in hospitals, that there would be the inability to give the basic level of care that people needed. When I said that we needed to stop the NHS being overwhelmed, and I set that as an objective, what I meant was that people in this country have a right to healthcare from the provided free at the point of delivery according to need, not ability to pay. That is incredibly important and has been part of the social fabric of this country for more than 75 years. And I wanted to protect that, not only because it's the best way, one of the ways of saving lives and protecting life during the pandemic, but also because of the very strong attachment that I and most people in this country hold to it. Of course, every part of the NHS was under pressure, and some individual parts found that pressure overwhelming. But the system as a whole withstood the pressures thanks to enormous efforts from literally millions of people. And as I say, I spent as much time as I could on the front line, doing night shifts when I could, actually participating myself, because I found as the leader of the health system, I needed to be on the ground listening to people and finding out what was actually happening, as well as, of course, what was being provided to me officially in my role as Secretary of State, which you can see in the paperwork.
All right, well, let me ask you about that. What insight did that, the efforts by you to visit GPs, visit hospitals and the like, what insight did that bring to you as the Minister that actually helped inform your response or inform a decision that you made? Well,
there were endless. I'll give you one example that is incredibly clear in my mind. In the early stage of the second wave, in the peak of it, really, in January 2021, I went to Basildon Hospital and I did a night shift. And because I'm not a trained doctor, my role was to help the nurses to turn patients, because patients on a ventilator needed to be turned regularly. And typically these patients needed 2 or 3 people to help turn them. So I was one of the team, and I spent the night doing that. But the thing I really took away from this was I was in the intensive care unit, and there was a patient who was lucid and talking, and but obviously unwell, and you could see his oxygen levels were low and falling, and the doctor took the decision that he needed to be intubated and went and asked for the consent of that patient to be intubated. And he gave his consent, and within about a minute, he was anaesthetized and intubated. And the doctor came over to me and said, I think he's got a less he's got less than a 50-50 chance of waking up. And seeing this man go from lucid and talking to effectively, likely never to open his eyes again was deeply moving. And of course, people working in the ICU saw this day in, day out, many times a day. And the doctor then had to go and call the patient's wife. And I remember thinking, the patient didn't even say, "Can I speak to my wife first?" He knew what the chances were if you are intubated. And then afterwards, I was visiting the wellness centre that the hospital had put together to look after staff, and the doctor came down to see me there and burst into tears and said, "We're in a second wave, Secretary of State. You cannot allow a third." And I'd spent the whole autumn before that fighting to get the lockdown for to stop this second wave that was obviously coming, and the impact of that. I was absolutely. I mean, I'd been determined to do everything I could, but that made it even stronger.
Now, Mr. Hancock, I think you've given that example before, and it's not to diminish the impact that it had on you. But having seen that, what did you do when you went back to work the next day to think, I am going to try to do something to help those staff members or to help the patient?
Well, you have to remember that at that time I was in a battle with other parts of government to ensure that the measures that we were taking were enough to stop the spread of the virus. And there were pressures from others to try to release the measures, in my view, too soon, and it stiffened my resolve to resist those measures, to relax too soon. And we were also in the middle of the vaccine rollout, which was the ultimate way out of it. And it was critical that we didn't release too soon before the vaccine had the chance to work. And so that was a direct consequence of that particular example. But there's other examples we can talk about if you like.
All right. May I just ask this? It's not always easy to focus on the scope of Module 3. And Her Ladyship, though, has heard about lockdown decisions and the rightness or wrongness and the timing of them. I'd like, if you can, during the course of your evidence, to really focus on things that practically help the NHS. I appreciate that if we all go into lockdown and we all don't get infected, it's inevitably going to help the NHS. But for actual practical things that we might want to adopt in the future or things we might not want to do. So can I just ask you to keep that in mind throughout your evidence?
Of course, although you'll also understand that the operation of the NHS is independent, so you need to speak to the Chief Executive of the NHS in order to ask some of those questions.
Yeah, well,
my role was overarching, protecting the system as a whole.
I follow that. That brings me on to your role. You've told us, I think, you don't have a medical background. I think you actually have a background as an economist, is that right?
Yeah.
And then became MP for West Suffolk in May 2010 until May of this year.
Until July of this year.
July of this year. It says May in your statement, but not to worry.
Oh, no, May, when the election was called, whatever, yeah.
All right. The role of Secretary of State, as you've just said, is to set the strategic direction, secure the budget, and support the delivery of health and social care.
Yeah.
And Mr. Hancock, your statement sets out how decisions were made, the makeup of your red box, your early starts and your late nights. And so I'm not going to ask you about that. Can I ask you, though, about your relationship with your devolved counterparts?
Yeah.
We know that there are Four Nations calls. We know that you met them on a number of occasions, certainly at the beginning. But can you just help, not about lockdown decisions, but how was your relationship with them in relation to decisions that affected healthcare in each of the four countries?
Well, the running of the NHS in each of the four nations of the UK is, of course, devolved. So, as you know, at the start of the pandemic, I thought that it was important to bring the four health ministers together, and I went and visited the other three, and then from then on we had a weekly Zoom call. Those meetings were, I say Zoom, I can't remember what platform it was on. Those meetings were incredibly helpful for understanding and discussing the decisions that we were making, as well as the practical interaction of the systems. But the NHS itself is devolved. So really, they were mostly concerned with things that you just said are outside the remit of this module, because they were mostly concerned with things like PPE availability, testing, lockdown decisions, vaccines. The operation of the NHS was essentially for each of the four of us on those calls, although in England, independent and delegated to the Chief Executive of NHS England.
All right. May I ask you, please, about a readout of one of the weekly calls? Can we have on screen 279766_1? This is a readout of a meeting between you and the ministers in the other nations. It's the 18th of May 2020. And if we just scan down the page, we can see there a number of topics, not all of which are within Module 3's scope. But at the bottom bullet point, Jean Freeman made a request to reset the relationship between the English and Scottish administrations regarding COVID-19 handling. All on the call agreed and are keen to ensure they have conversations and share information and confidence. Can I ask you, was that resetting of the relationship anything to do with the matters that are within Module 3 scope, or is that matters that are unrelated?
No, this was all about how Nicola Sturgeon was causing all sorts of difficulties.
Right, I'm not going to ask you about that then, Mr. Hancock. Generally speaking, though, was there good collaboration between you and your
at a health
counterparts?
level, there was excellent collaboration between the CMOs, who themselves had their own call, and then between the four health ministers. And you can see from the minutes and the WhatsApp group that we had a really genuinely collaborative approach.
All right. One of the matters you did say, not in relation to the devolves, was in, I think, your witness statement to an earlier module, you spoke occasionally of inappropriate political interference from number 10. And I'd like to ask you, please, whether that interference related to any of the matters within the Module 3 scope as well.
Well, of course, some of it did. For instance, the biggest interference that caused difficulties was within testing, where some of the political appointees in number 10 caused incredible difficulties. But that's not to do with this module. Within the running of the NHS, we were protected in a way because of the independence of the NHS, and therefore many of the operational decisions were taken by the Chief Executive of NHS England formally, and therefore if there were people being difficult from number 10, part of my job was to provide a shield from that, and I know that I ruffled some feathers in doing so. But my job, ironically, was also to protect the NHS from some of that.
All right. So we shouldn't. It's not the case that you wanted to bring in testing on X date and someone said no, you can't, or you wanted however many millions or billions and someone from number 10 said no, you can't. We shouldn't read that into that.
Well, obviously, I had to go and get the budget, but one of the things the Treasury was very good at in the pandemic was ensuring that the NHS had the budget available. Budget constraints were rarely the immediate problem. It was resource constraints more broadly.
All right. Can I ask you, please, about asymptomatic transmission? And I know that you have answered some questions on this topic before, but it's really about the effect it had on hospitals and the staff working in them and the patients.
Absolutely, yeah.
Now, look, I know that you have said previously that this is an area where you considered you failed. And you said that you failed to drive home the importance of asymptomatic transmission. And you said that you consider this had very significant consequences. From your perspective, what were those consequences for the healthcare system?
Well, the challenge with asymptomatic transmission was that the system as a whole and the advice to the system, the clinical advice, was that asymptomatic transmission could not be considered a material factor until, and that only changed in April 2020. And my failure was my inability to override that consensus. But I've described how that was a global clinical consensus. But the consequence of that was that there was the formal advice going into the system was that asymptomatic transmission should not be considered as the most likely cause of transmission. Now, in terms of the impact on the NHS, though, in early March, we took the decisions to increase PPE requirements within the NHS, presuming that anybody could have COVID. And one of the reasons that there was such a sharp increase in demand and all the logistical and practical consequences that I'm sure we'll come on to, was that we increased the demand for PPE by increasing the recommended use of PPE within hospitals. So, in a way, whilst the formal advice was that asymptomatic transmission wasn't the most likely and therefore shouldn't be considered as the basis for policy decisions, within the NHS, working alongside Ruth May, who had the formal responsibility for this within NHS England, we actually effectively overrode that and put in place PPE requirements that took into account the possibility of asymptomatic transmission. So I wouldn't regard that as an area where this had as big an impact as in other areas.
We're going to look at PPE, obviously.
Sure.
But can I just track through for those who aren't familiar with the chronology of asymptomatic transmission? You say in your statement that from about the 26th of January of 2020, you were concerned about reports from China of asymptomatic transmission.
Yeah.
And you say this, that you asked officials for advice on that.
Yeah.
And you say this, at this stage, PHE, Public Health England, was adamant that a coronavirus could not be passed on asymptomatically and that tests did not work on people without symptoms.
Correct.
Who at PHE was that adamant?
The then clinical leadership.
Right. And how was that communicated to you, Mr. Hancock?
In every time I asked. So from the 27th of January, I had daily meetings on COVID. And for instance, Sharon Peacock would come to those meetings, and she was one of the people who made this argument very firmly to me. Tests don't work if people don't have symptoms, and there are 6 known coronaviruses that affect humans, and none of them have asymptomatic transmission. So that was the strongly held view at that stage.
Can I pause you there so we can just look at the 27th of January? It's set out in your statement a meeting record. Could we have on screen 41858_13? And one can see there, you say you raised concerns with officials.
Yeah.
The private secretary's note of the meeting said it opened by outlining your concern upon hearing the virus is transmissible when patients are asymptomatic and need the plan and set out the need for a plan.
Yeah.
The CMO said there is still a lack of clarity over what the Chinese official position is, but he said it was unlikely to transmit while patients were asymptomatic, but this is unable to be definitive. And at the end of that meeting, the record note says you asked the department to gain clarification from China on whether asymptomatic transmission is occurring and to scenario plan accordingly.
Absolutely.
And I think you also had some evidence from Germany as well that was pointing towards asymptomatic transmission.
Yes, I was close to the German health minister, Jens Spahn, and he was worried about this too, and I remember speaking to him on the phone about that.
Right. So there's varying views. There's some evidence of asymptomatic transmission from China and Germany. PHE are telling you, on that other hand,
No.
No. On what basis was it that you trusted the advice of Public Health England, despite the reports to the contrary?
I challenged the advice from Public Health England repeatedly from then over the next 3 months, and eventually the formal advice was changed. I mean, for instance, I went to the lengths of setting up a phone call with the Director General of the World Health Organization about this evidence from China, and he said that it was a mistranslation. So the whole global clinical system was trying to say there's no asymptomatic transmission, and I kept seeing straws in the wind, if you like, anecdotal evidence that there was, and continued to challenge on this point.
Mr. Hancock, are you aware that the WHO guidance, not to say it's not important, but it's not binding
Correct.
on England,
So
is it?
the WHO guidance, of course, influences public
Yeah.
health views, and the views of Public Health England, which is an agency of the department, were clearly agreed on it with it. I could not, at the stroke of a pen, overrule that advice. That is not within the power of the Secretary of State.
So just pausing here now at the end of January 2020, given that there is some evidence
Yeah.
of asymptomatic transmission, did you at that point consider there needed to be any specific measures put in place to protect
Yes.
healthcare workers?
Yes.
What did you do at the end of January as far as the healthcare workers were concerned?
Two things. The first is we'd already brought in a set of PPE guidelines for what wasn't even called COVID-19 at that point, what became COVID-19, called the guidelines around high consequence infectious diseases, which is essentially, in lay terms, hazmat suit style PPE. You can see in the minutes I was at that time asking to ensure that we had that PPE available, because this was before there were any known cases in the UK. I think they came around this time. The second thing that I did was, anticipating that there would be a huge rise in the amount of PPE, I instructed the opening of the PPE stockpile, which had been, I knew was constructed for these purposes. And also in January 2020, I ordered the mass purchase of PPE from around the world, knowing that there was going to be huge global demand. So that work started in January 2020, buying the PPE.
All right, we're going to come on to the stockpile as well, Mr.
Yes, but it's not just about the stockpile,
No.
it's also about buying from around the world.
No, I follow that. Jump forward to April, please. And even on the 2nd of April, the WHO was saying there'd been no documented asymptomatic transmission.
Yeah, but by its nature, it's very hard to document because it's asymptomatic. So that wasn't evidence that there wasn't asymptomatic. It was deeply, deeply frustrating.
It wasn't a criticism of you.
No,
it was just to set out.
I don't feel the criticism.
position.
What I'm expressing is how I felt at the time, which is like you're trying. They were trying to prove a negative, if you like. They were saying because there's no documented evidence, therefore we can't say that it's happening. It's like, well, you can't see asymptomatic transmission. You can't see it. That was the problem.
Yeah, that's the danger. I follow that. But this is where I want to get to on this point. On the 3rd of April, the CDC in America
Yeah.
publish a study, don't they?
Yeah.
Saying that there is.
Yeah.
Right. And you say in your statement, you instructed the department to review its guidance. Which guidance were you talking about there, Mr. Hancock?
All of the guidance that had been based on the presumption of no asymptomatic transmission.
And did that include, from your perspective, a review of infection prevention and control guidance?
Absolutely, yes.
Right.
Yeah, you've got to remember, as the evidence shows, there was high transmission in hospitals. And nosocomial infection in hospitals is always a problem, even when there isn't a pandemic. It is the responsibility of NHS England to ensure that it's minimised. But I was deeply concerned to stop this the problem of people catching COVID in hospitals, and this was a repeated problem. I mean, the use of testing within hospitals is another issue where I was trying to drive the use of testing.
Pause. I'm going to come on to it.
Okay.
All right. I can sense your frustration, but let me just ask you this. Clearly the advice to you was don't assume asymptomatic transmission until we know it's happening.
Correct.
All right. Some may argue that you should assume it is happening until you know that it's not happening.
Absolutely.
You're the minister in the middle.
Yeah.
Given the uncertainty about whether or not a new virus is or isn't transmitting asymptomatic, what approach do you think should be adopted in the event of a future pandemic?
The precautionary principle, absolutely, which we did on things like the guidelines around use of PPE within hospitals.
So one should assume that it is happening until you can prove that it's not.
That would be a very that would be the safer assumption in future. Yes.
All right. And you would say, therefore, that your IPC guidance, for example, should be predicated upon that assumption that asymptomatic is happening.
That asymptomatic transmission is happening. And there's another thing that I would recommend, which is challenge studies, which is where you intentionally infect consented adults, obviously, in order to find out. So by using challenge studies, you can investigate this question better than if you refuse to use challenge studies. And I think the barriers to using challenge studies was one of the problems, not on this, and in particular on you can accelerate vaccine testing using challenge studies.
I stopped you as you were going on to talk about testing, but clearly the ability to test for asymptomatic transmission depends on you having the capacity of testing available.
Yeah, but it also depends on your presumption of whether a test works on somebody who's asymptomatic, and we were told that they didn't, and that wasn't true.
No, all right. A number of the witnesses have impressed upon her ladyship the need for testing to be up and running ASAP.
Absolutely.
All right, and I take it from that answer you wouldn't disagree with that.
I spent, you just, in one of the earlier questions, you said jump forward from January to April, and I thought, well, that's quite a big jump. A lot happened in February and March in the health department, and one of those things was driving up testing capacity, as the records show.
All right. Can we turn to NHS overwhelm? And in your statement, you say, in terms, one of the most considerable achievements of the UK during the pandemic was ensuring that the NHS was never overwhelmed, or in other terms, that the NHS was always available to all according to need, not ability to pay, and we did not have to ration care.
Yes.
All right. There was, do I take it, no agreed definition of what it meant within government as to what overwhelm meant or overwhelm looked like?
There was a. That's not quite right. There's a sense of what overwhelmed looks like. It's not a. It's accurate to say there's no formal definition, but the best approximation you could have, and what I held in my mind at the time for it to mean was what happened in Lombardy in February 2020.
So do I take it from that it was a desire to ensure that if people needed a ventilator, they got it? If they needed to get into ICU, they were able to get an intensive care bed?
Yes.
Right.
What it does not mean is that the availability of these things were not stretched, and in some cases deeply stretched. For example, I'll give you an example of what I mean by that. In normal times, one nurse cares for one patient in ICU.
Correct.
In order to ensure that there was enough ICU capacity, one of the things we did was stretch that so that one nurse cared for 6 people. Now, imagine the impact of that on that nurse, on all ICU nurses during the pandemic. It's a deeply challenging situation. It's very hard. And there will always be boundary cases where people feel that they or their loved one should have had that level of care and feel that it wasn't available. And I absolutely understand that, and I saw some of that. The system as a whole, though, withstood the challenges. And if I might just add one other thing at this point, it was not only, what I was saying was not only accurate in the big picture sense, it was also important to say, because at the same time as having to tackle COVID, we wanted to ensure that people who desperately needed NHS treatment for other reasons, where it was safe to do so, would come forward and get it. And that balance between protect the NHS, i.e. don't use it unless you have to, and please do come forward if you really need it, was something that was in my mind throughout this in terms of how we communicated.
All right.
Can I interrupt? I'm sorry.
No.
Ms. Carey. You said that the NHS was always available to all according to need. Well, it was always available to those with COVID who needed ICU treatment, but it wasn't always available to those who needed cancer screening or who needed a major elective surgery like a hip operation. So I can understand why you say we had to do that, but I don't understand how you can maintain that it was right to stop non-urgent elective care.
Yeah.
And then say, but it was always available to all according to need, because it wasn't.
Well,
was it?
I don't think that I don't want to get into the linguistic analysis of it. What I care about is the substance. And the substance is that it was not safe clinically to go for some cancer treatment during the pandemic, because cancer treatment sometimes involves reducing the immune system. It was better to delay some non-urgent operations in order to protect both the space in the NHS and the patients themselves, because as we know, you're more likely to catch COVID in a hospital than in almost any other setting. So that, of course, those decisions were taken, but it depends how you define need, and need to, at the same time, needing to protect people from the pandemic. So I think that I think the broad thrust of the NHS being available is true, and and whilst individual parts were under an enormous pressure, like there was a time when 111 was under massive pressure, there were many hospitals individually under pressure, and we'd triage patients to other places. But the overall point is that we did not have a collapse in the system.
Ms. Carey.
I'm going to come back to that, I suspect. You mentioned ratios. So let me deal with that at this stage. You set out in your statement that it was you that suggested to Sir Simon Stevens, the then Chief Executive of NHS England, that ratios be stretched. And when was it that you suggested that to Sir Simon?
I don't recall.
Are we January, February, March? Can you help at all in the timeline?
It will have been during the period when we were building the Nightingales as well. So was probably February 2020. But we'll be able to find, it'll be there in the paperwork.
It's not meant to be precise, it was the 10th of February. That's not what I'm asking you. It's just generally to try and get an overview of what point it was you decided to ask Sir Simon to stretch the ratios in the way that you did.
So one of the things that we would do, yes, so the answer to the question is February.
All right. And on what basis did you make that decision?
So it was clear that there was likely to be very significant pressure on the NHS. And I wanted to ensure that there was as much capacity as possible in the NHS. And I was pushing for the building of extra hospitals. We'd seen that the Chinese had built a hospital in 2 weeks. And one of the responses that came back was, there's no point in building extra hospitals because we don't have enough staff. To which my response was, well, what we're going to have to do is stretch ratios of the staff-patient ratios as much as is clinically possible, even though that's difficult, and at the same time build more hospitals, which is what became the Nightingale project. So it was essentially, the reason I pushed that was because I was rejecting advice that we couldn't increase NHS capacity in short order.
Now, the stretching of the ratios into Nightingales is a slightly different matter, because we have heard evidence that they were being stretched within an ICU unit within the hospital itself, because the ICU unit had to expand by double or if not triple its capacity.
Yeah.
All right.
So it's not just the Nightingales. That was another part of the overall stretching of the NHS's capacity to deal with this. And there's one other factor which is important here, which is that in normal times the NHS is dealing with many, many diseases, obviously. The pressure wasn't just the pressure of numbers. It was the pressure of very large numbers all suffering from exactly the same disease. And so that led to acute pressure on particular aspects that were necessary for dealing with COVID-19, like ventilators, oxygen supply, etc., that may not have been necessary for other purposes. So it was not just the pressure of numbers, and at this point, remember, anticipated numbers, because there were very few in hospital in February. It was the pressure of a very large number of people presenting with the same condition.
Okay. On what basis did you, or were you advised to go to 1 to 6 as opposed to 1 to 3, 1 to 4? Who was telling you that's an acceptable stretching?
That was an NHS decision.
All right. Did you appreciate that in the context of intensive care, stretching to ratios of 1 to 6 would mean providing a very different level of care
Yes,
to
of course.
patients? All right.
Yes, of course.
I think
Not only did I appreciate it, I saw it for myself. I mean, I talked to the ICU nurses. I took the advice. I think it probably came through Simon Stevens, probably from Ruth May as the chief nursing officer. But it would have been a Simon Stevens decision, actually, the actual 1 to 6. But did I appreciate it? Absolutely.
Well, let me ask you this. How did you assure yourself that stretching to those ratios wasn't putting the nurses under absolutely intolerable pressure?
Well, the actual decision will have been a decision, as I say, for Sir Simon Stevens, so you'd have to ask him that. My role was to say we have to expand NHS capacity and to push against the initial feedback, which is that the limitation on this will be the number of people that we have.
All right, but the question I wanted to know was how you assured yourself, not the actual ratio, it doesn't matter for these purposes of 1 to 4, 1 to 6, but how did you assure that the stretch per se didn't put those nurses under intolerable pressure?
I had to rely on my clinical advisors and the NHS England advice, and I'm sure the CMO will have had a view on this as well, that was an appropriate level to go to. You have to remember that the formal running of the NHS was independent, and so this really is a question for Simon Stevens.
Well, given that you were suggesting to him that the ratios be stretched, people might forgive me for asking you.
No, it's totally reasonable to ask
assure
me.
yourself that they weren't put under just the most immense strain.
Yes, but that's if I may say so, a slight misunderstanding of how the system operated. My job was strategic. It was to drive the system, but also to accept advice from the system. So the conversation would have gone, we need, over a period of days or probably weeks, we need to ensure we expand NHS capacity. Can we build more capacity? And the first response was, there's no point doing that because we won't have enough staff. Can we stretch the staff numbers? They would have come back and said, yes, we can. We think that it's okay to stretch them to 1 in 6. And I would have said that, as you said, the degree of stretch, whether it's 1 in 4, 1 in 6, was not a decision for me. And that's how the system operated. I was strategic, but really for all of these questions, you are going to have to ask Simon Stevens because it was he was running the NHS, remember. I was the Secretary of State, and we worked very closely and very well together, but there was a clear distinction. And this section is about the NHS, so it's perfectly reasonable to ask him.
All right. Let me ask you not about the impact on the staff that were stretched in that way, but on the impact actually on those in ICU. And could I have on screen, please, INQ 480139_7. I think, Mr. Hancock, you've been sent an extract from an ICNARC report who look at intensive care data. And we have heard from Cathy Rowan, who heads up ICNARC. She told us, if one looks at paragraph 6.1, that prior to the pandemic, ICNARC reported that how busy an intensive care unit is on any given day impacts on patient outcomes.
Of course.
With higher strain associated with higher acute hospital mortality.
Absolutely.
And the strain is the mismatch there between supply and demand, availability of beds and staff or other resources, and the ability to admit those that were needing critical care. And their ultimate conclusion, if one goes over the page, please, to paragraph 6.4, that when they adjusted for potential differences in important patient factors compared to typical ICU strain, they found significant association between exposure to higher ICU strain and higher acute hospital mortality.
Yes.
Both for those with COVID
Yes.
and those in ICU that were not COVID.
Yes.
Higher strain, higher mortality.
Absolutely.
You don't sound surprised by this
I'm
finding.
not surprised at all, and we said it at the time. And you have to remember that I was trying to drive up NHS capacity because I know it's technically outside the remit of this particular element of the inquiry, but really my role was overarching rather than specific to the NHS. Because you have to remember at the same time, I had the Cabinet Office and others trying to tell me that we shouldn't be taking the actions that I thought were going to be necessary in order to stop the spread of the virus. And so I knew that we were going to have a problem. And therefore I had to increase hospital capacity as well as try to reduce the spread of the virus. So not only do I know this, and I saw it, but we articulated it. And the Chief Medical Officer in one of the early press conferences set out that there are 4 reasons that you get more people dying in a pandemic. One is the direct impact of COVID. The second is the impact of inavailability of health services that would be available other times, as per our exchange earlier, for instance, cancer care. And then, of course, the impact on the of the measures taken for instance, lockdown, and the fact that if you have higher hospital admittance, then the treatment of those with COVID becomes more difficult. And we saw this in the first phase, and we saw it in the second phase as well. And it's one of the reasons that I feel so strongly about the need to ensure that we're ready to bring in measures to stop the spread of the virus next time around.
Do you think, though, Mr. Hancock, if you just stand back for a moment, that the fact that the nurses are being stretched to the ratios that we've looked at and the potential adverse consequences for those who are in ICU, doesn't that not, in fact, demonstrate that the NHS was, in fact, overwhelmed?
No, because people could get treatment. The treatment was not as good as normal, in the same way that the waiting times for a knee operation was not as good as pre-pandemic. But that is not the measure. I'm not saying that the NHS was perfect in the pandemic, and I'm not saying that it wasn't severely pressured in many areas and that pressure had consequences. The point of saying that it wasn't overwhelmed is that the system as a whole withstood the pressure. And as I say, that is not only accurate, but it was also important to say during the pandemic because we had to reassure people that the NHS remained there for them. Remember, there were people who didn't turn up. They might have found a lump and didn't go to their GP because they thought, I don't want to put pressure on the NHS. And we've seen that in the excess mortality figures of people who didn't have COVID, as well as people who died with COVID. So I was acutely aware of this, and it weighed heavily on our decision making at the time.
Let me come to intensive care capacity then, please, because you say in your statement that at no stage were you advised that intensive care capacity was exceeded. I understand there may have been some individual hospitals where intensive care capacity was exceeded and patients needed to be transported elsewhere, but there was capacity in the system as a whole. And are you referring there to not just the baseline capacity, but the capacity the hospitals had once they had surged up?
I am, but again, the detail of that and the triage of people to a different hospital, if a hospital became full, was core business of NHS England, and I didn't get involved at a day-to-day level.
No, I wasn't asking you about the transfers.
Yeah.
It was just simply that when you're talking about ICU capacity, in your mind, that's baseline plus whatever surge capacity there was.
Yeah, of course. At only baseline capacity, there was no way that we could have treated as many people as we did.
Were you made aware of how far over baseline hospitals were operating?
Yes, and I remember I was visiting hospitals whenever possible, and I saw it. I remember going into Barts and seeing the ICU beds, which in normal times have a stack of equipment behind them on the wall, and there were just far more beds than there was space for. Of course, I saw it. I saw it for myself. Yeah.
In England, we've heard that NHS England reported occupancy based on the surge capacity, which sometimes suggested there was a lot of beds available, but didn't really alight upon the fact that these hospitals were operating at double their intensive care
exactly.
capacity.
And you've got to remember also...
No, can I finish? Thank you.
Of course.
What I wanted to ask you was, do you think in reporting that way, that gave perhaps a more positive picture of we've got a lot of beds available, it's okay, rather than demonstrating that some of these hospitals were running 20 or 30 more beds?
Yeah, absolutely. But the point I was going to make was precisely to your question, which is that you also have to remember that at the start of the pandemic, we didn't have... I couldn't get an answer out of the NHS about how many beds they had. And by the end of the pandemic, that data was much better. But, and in the second phase, it was much better. But that sort of definitional issue, of course, we should consider now as part of the inquiry. But at the time, it was a moot point. Because if you say to the NHS, how many beds have you got? And they say, well, it all depends how you define it. Then whether the extent to which that includes surge or not is second order. And just in their defence, the reason that they couldn't say exactly and definitively how many beds is because it depended on how many people were available. Because the NHS counts beds according, not just the physical bed, but the bed with the ability then to support a patient, which includes people and equipment and what have you. If you have a bed, if you have an intubation bed with no oxygen flowing to it, then it isn't. Then it's no use for these purposes. So that's why it was difficult. So I'm not blaming the NHS for inability to measure that at the start. What I'm saying is these things were difficult to measure, and so picking precise points in the methodology it was not our lived experience. But this was another reason that I went to hospitals and went and talked to people.
It's not so much about whether it's difficult to measure, but from the public's perspective, if you're saying there's still 10% of beds available across the country, it might be thought by some that's presenting a rather rosy picture, when in fact those hospitals were operating double, triple their usual baseline capacity.
And in some cases...
But do you agree it presented a rosy picture or not?
I think that by the end of the pandemic and in the second phase, we were able to present this much more accurately. Whether it was rosy or not in the first instance, as I say, I don't think you can define that because we just didn't have the data available at all.
Can I give you an example, please, of some evidence that we've heard from Queen Elizabeth Hospital, Birmingham? And I want to know if this kind of information filtered up to you. They had, in March 2020, 67 ICU beds, and they went to April, following month, to 126, so nearly doubled.
Yeah.
That meant for them finding 205 additional doctors, 429 nurses, and an extra 59 actual physical beds. At a time when they had 25% absence of work force due to ill health. Now, were you being told that's actually... Let me finish, please. Were you being told that's actually what it means if a hospital has to double up its surge capacity? We've got to find vast numbers of staff.
Yeah, not only was I being told, but I was seeing it. You know, I went to the Queen Elizabeth Hospital in Birmingham. I saw it for myself. So, yes, of course. And I was deeply involved, for instance, in trying to hire more doctors and get doctors who had retired back into the workforce in order to try to solve these problems. So, you know, the reason I interrupted is the question gives the impression that I was somehow sat in an office this whole time. I was out on the ground as much as I could be and talking to people about what the real world problems were, as well as getting the official advice through paperwork. That's how you lead in a crisis as big as this.
Can I ask you to just pause for a second? Some of these questions are not designed to trip you up, Mr. Hancock, but I want to understand whether some of the detail that we've now heard did in fact make its way to you. That's all I was asking.
Okay, and I'm being emphatic in my response that it's not only did I get it in reports as much as the data was available, but I chose to go out there and see it for myself.
Now, were you made aware that not everyone who needed an ICU bed got an ICU bed?
Yes. In individual cases that happened, yes.
we've heard a number of examples, some of which we've provided to you, and I'd just like to take you through some of them for your comments on them, if I may.
Right.
You are aware, I think, that on the first day of evidence, we heard from Mr. Sullivan, who told us about his daughter Susie, who had Down syndrome and was taken to hospital.
Yeah.
And she was refused admission to ICU because what was recorded on the notes was she had cardiac comorbidities, she had a pacemaker, and had Down syndrome. And did you get reports like that people were being denied ICU care?
I did get reports like that. And I also got reports about the misuse of DNR notices as well.
We'll come on to that.
Well, they're all part and parcel of the same thing, because it's about availability of care.
Yeah.
And if you recall, I was also getting advice from the BMA and others that we should have a code of who you should give care to and not. And I'm
going to come on to that as well.
Yes, but what I'm saying is I was deeply involved. Of course, not only did I know these things were happening, I was fighting on behalf of those to whom it was happening.
Can I just stick with what happened to Susie? And can I have up on screen, please, INQ 483295_8. This, Mr. Hancock, is a serious incident investigation report that was carried out into the care that she received. And one can see that she was admitted to intensive care. The essential advice was if she worsens, she should be considered for escalation up to ICU.
Yeah.
And then in due course, about 3 hours later, was deemed not suitable because of her cardiac comorbidities and Down syndrome. Can we look, please, at what was going on in the hospital at the time? And if we highlight, please, the paragraph beginning, it is recognised. It is recognised that intensive care units were having to clinically prioritise patients.
Yeah.
Occupancy at this particular hospital on the 27th of March, the day that Susie was taken in, was 27.
Why is the hospital redacted?
Because it's not necessary to name the hospital. This is just an example of issues that the inquiry's been made aware of. But put that to one side for a moment, Mr. Hancock. Just concentrate on what was going on in the hospital. There was 27 level 3 patients, which was already an increase from the 21. And the baseline there was 23 beds. Normally, staff for 9 level 3, which is the highest level of care, ICU beds, and 14 level 2. So they were already running at over capacity. Did you ever get examples of particular problems like this brought to you? I know you're looking at it from a national picture, but did you ever get
Yes, of
this
course.
Right.
Yeah.
It might suggest that in her case, the decision was wrongly taken to deny her ICU, or it might be that the notes are very badly and incorrectly drawn. But either way, do you not think this is an example of tragic overwhelm in the NHS?
This is an example of a tragic case, and serious case reviews are intended to get to find out what happened, and individual clinicians make judgments like this in normal times, but made judgments like this because of the pandemic, more so. And of course there was enormous pressure, and of course it had consequences, absolutely.
The inquiry has sent you its research conducted by IFF, and can we just have a look at that, because it's not an isolated experience. Can I have up on screen, please, INQ 499523_, page 3. And we have there a summary of the research. I'm not going to suggest to you, Mr. Hancock, this is representative of entire healthcare professionals, but clearly a large number were surveyed, over half of whom, 58% of healthcare professionals, reported that some patients could not be escalated to the next level of care due to lack of resources during either wave of the pandemic. This is about wave 1 and 2. A&E doctors and paramedics were more likely to have ever being unable to escalate care. And if we just go on to page 17, and if one looks at the bottom two responses from critical care nurses and critical care doctors, during the first wave, those doctors were significantly more likely to have ever been unable to escalate care. 20% and 19% of nurses and doctors, respectively, said that that happened to them on a daily basis.
Daily basis, yeah.
You don't sound surprised by the findings of this research either. And in fairness, neither was Professor Whitty when we asked him.
I'm not surprised in the least. I mean, and of course we knew that these pressures were intense. Professor Whitty himself worked on the wards.
Yeah.
I visited them, and I worked in an appropriate capacity as a non-clinician. Of course we knew, absolutely. And this is what we were trying to prevent. This is what we were trying to prevent by fighting for lockdowns, by buying as much PPE as we could get our hands on, by developing the testing. I know that you say these things are outside the room, but you can't present this as if it's sort of desiccated statistics. This is what was going on in the ICUs of the nation. This is why it's so important that we're prepared to stop pandemics before they start. And so, absolutely, yeah.
Did you tell your cabinet colleagues and the Prime Minister, then Mr. Johnson, of all of this material that you were well aware of?
Yes, as much as was. Of course, we talked about it. Yeah, yeah.
So you made.
I don't know the detail of how much. Whether I presented a particular slide or what have you. But yeah, absolutely. Stopping the NHS from being overwhelmed was something that I talked about frequently, and I can see that you've picked up on that language as if I was trying to say everything was perfect, and that is emphatically not what I meant, and it is not how I mean that. And I understand if that is how it could be interpreted, that was not the reason. It was used as a term of reassurance, and that is true. But it was absolutely part of our discussions to say, in fact, that, the then Prime Minister would say it mustn't be topped out, I remember, because I thought that was an unusual phraseology. But yes, this was part of our discussion, the enormous pressure on the NHS. Yeah.
So you made it plain to your cabinet colleagues and the Prime Minister at the time that numbers of doctors and nurses were unable to provide the level of care that their patients needed. You made that plain to all your colleagues. You didn't present a rosy picture that some have suggested.
I have in previous modules been accused of painting a rosy picture. There are, for each of those, as I said in those modules, for each of those specific accusations, there are inaccuracies in the other accounts that we didn't go through in detail. But all you need to know, Chair, is that I was not one for buck passing, and maybe we've seen a little bit of that in previous modules.
I ask you this because in your Module 2 statement, you said, had the NHS been overwhelmed, treatment would have had to be rationed. And it was being rationed, wasn't it, Mr. Hancock?
What I was trying to avoid, and what we successfully avoided, was an overall rationing to say people, according to these characteristics, aren't going to be cared for. That's what would have happened if we'd let the virus get more out of control. And we managed to avoid that both in the first and the second phase. Did people get as good care as they would have done in normal times? Of course not. There was a pandemic.
No.
So I think we're agreeing with each other.
I think we are.
Yeah.
And it's just this. If people can't get into ICU, for example, because the doctors don't consider that they can be escalated, we've sent you an ICNARC report which suggests that older people...
You sent me endless evidence showing that the NHS was under incredible pressure, as if I wasn't there.
No, I know.
But I visited as often as I could. I talked to the doctors. Of course, I relied on the official advice that I was getting, but I went to see it and I spoke to people regularly, as did my senior advisors. We we were emotionally engaged in trying to stop this from being from getting worse, frankly.
I want to deal with one final aspect on this, please. Can I ask, please, that we look at a clip of footage from a witness that gave evidence by the name of Kevin Fong. I think you've seen his transcript, but I'd just like to watch a short clip of what he told us. Help me about what the matron said about the scale of death that they had observed in that unit.
Yeah, and this is one of those things that is really very difficult to capture in figures. The scale of death experienced by the intensive care teams during COVID was unlike anything they had ever seen before. They're no strangers to death. They are the intensive care unit. They look after some of the sickest patients in the hospital. But the scale of death was truly, truly astounding. I went into this and other hospitals where they said it would be routine to see 3 to 5 deaths a day. I worked on a shift where we had 6 deaths in a single shift. Another hospital told us that they had 10 deaths in a shift, 2 of whom were their own staff. We had nurses talking about patients raining from the sky, where the nurses said that one of the nurses told me that they just got tired of putting people in body bags. Now, the hospital where they said that sometimes they were so overwhelmed that they were putting patients in body bags, lifting them from the bed, putting them on the floor, putting another patient in that bed straight away because there wasn't time. We went to another unit where things got so bad, they were so short of resource, they ran out of body bags, and they were instead issued with 9-foot clear plastic sacks and cable ties. And those nurses talk about being really traumatized by that because they had recurring nightmares about feeling like they were just throwing bodies away. These people are used to seeing death, but not on that scale and not like that. And whatever the figures show you, the experience for them was indescribable. And when we talk about capacity in healthcare systems, the toll on those teams from that scale, and it really was like nothing else I have ever seen, and certainly not like nothing else those teams had ever seen in their experience. It was incredibly difficult.
Watching that now and looking at the number of different examples, real-life stories, do you think perhaps the use of the phrase overwhelm is not the right word to use when we're talking about how the NHS coped or otherwise in the event of a pandemic?
I agree with everything that was said in that clip, and I saw it for myself.
Yeah.
The system as a whole had to cope with more than it has had to cope with at any other time in modern history. And thanks to the work of those in ITU, did so. Now, of course, there were deeply challenging problems, as we've just seen, and that's there were countless examples of that. At the same time, we had people who were at risk of dying from not coming forward, and it was therefore important and my responsibility and my duty to ensure that the public felt that should they really need it, the NHS was there for them. And balancing these considerations was difficult and hard, but they did need to be balanced. And so that's why I used And I was right. Still believe I was right to use that language because, of course, there are individual. It's similar to PPE provision, right? I've said that there was no national shortage of PPE. That is true. It is verified by all of the paperwork. But that doesn't mean that there weren't shortages in individual places where the logistics couldn't get it to. And this is a similar concept. My responsibility was for the system as a whole, and then to try to relieve the individual pressures as much as possible. But it comes back to the point that this modular approach is sort of narrows the point. The best way to solve that problem was to have measures in place at a national level to stop the spread of the disease.
Right.
And that was core to my responsibility as well. So that's my explanation. And I think you can have an endless debate about the linguistics. What matters is the substance.
Well, yes and no, Mr. Hancock, because actually, if you make a statement like the NHS was not overwhelmed, and you can't get an ICU bed because you're old or you've got Down syndrome or because there aren't enough nurses, plenty of people would say that is overwhelm, wouldn't they? And that's why it's not just semantics.
No, I'm saying that the substance is what matters here. Right. And for instance, when an ICU didn't have any more capacity, the NHS's response was to then ensure that there were transfers available to other places because the picture was never even across the country. That is the system-wide response, but it doesn't take away from the individual pressures. And as I say, there were other reasons to explain why, and to use the word, the language that I did. And you have to take them into account as well. You just can't take one element of this response into account on its own. You can't do it because then you miss some other consideration that had to be balanced.
All right, let me ask you this finally on this topic, perhaps before we break. In your final paragraph of your statement to Module 3, you say this: finally, I would strongly recommend that an early objective of any future pandemic is to make sure the NHS is never overwhelmed.
Yes.
How practically do you suggest that can be achieved in the event of a future pandemic?
As soon as you see that a pandemic it comes back to the pandemic doctrine that we've discussed in the previous two modules. As soon as you see that a pandemic is going to require action, what are called non-pharmaceutical interventions, you get on with it straight away. You don't wait in the hope that it'll disappear or stick your head in the sand.
All right, so you buy more PPE, you start your surge capacity plans. Is that what you're talking about?
No, what I was talking about very specifically was bringing in lockdown measures as soon as they might be needed, because you're going to have to bring them in anyway.
Right. Outside of lockdown measures, thinking about it from the NHS perspective.
You can't think about the NHS response outside of lockdown measures. Okay. The system as a whole, this is an overall policy response. There were 7 elements of the battle plan, and you can't just say, well, how did that one work? You have to ask how the system worked, because it's impossible to answer the question without talking about overall measures, because we were in a pandemic. Obviously, but what I can say is, as well as lockdown measures, you of course also need to have an adequate and accessible PPE supply. You need to have a testing system that's ready to grow and ready to expand rapidly. You need to make sure that you can get a vaccine as soon as you possibly can. You need to undertake the challenge trials to understand spread, not just by observing evidence in the wild, so to speak, but by having a scientific approach to doing that and getting over the improper ethical caution around using challenge studies. You have to have an overall system response, and that is why I'm getting to the point of repeating myself, so I'll stop.
Would that be a convenient moment?
Certainly. I think some members of the public gallery here are suffering some distress at this evidence. Please can I encourage them to seek any support if they need it. But also, if people are at home feeling distressed, could they check out where they could get support?
Yes, thank you very much, my lady.
Thank you. past. Ms. Carey.
Thank you. Mr. Hancock, can I pick up on one of the things you referred to before the morning break, which was potentially some of the difficult decisions that may have to be made in the event that effectively there was no extra bed or there was 2 people vying for one ICU bed. All right. And we've called it an escalation tool, or in the event of saturation has been another way of it's been described.
Yeah.
Generally speaking, do you think ministers should be involved in such guidance? By which I mean not the actual detail of who might get the bed, but the need for a escalation tool per se.
Of course, ministers should be involved in the principled decision about whether such a tool is necessary, and also the level at which such decisions should be made.
What do you mean by the level at which
I was very strongly of the view that these decisions are best made locally, according to the local judgment of the clinicians with the most information, rather than through a national tool.
Well, that's what I wanted to ask you about, because I think you are aware that on the 21st of March 2020, the 4 CMOs commissioned guidance in the event that critical care was saturated. And I'd like, please, just to look on screen. This was intended to be a UK-wide tool.
Yeah.
Can we have a look? Thank you, please. I'll just read it out for the record. 478863. This is an email to you on the 27th of March. And just to help you, it was commissioned on the 21st and then not, in fact, published around the 27th of March. It happens in a very short space of time.
Yeah.
All right? And we've heard, just so that you know, from one of the doctors involved in drafting the guidance.
Yeah.
All right. Let me just turn up my document. But were you made aware, as this email sets out, that some local regions were requesting guidance, and in fact there was a desire by a number of different people working within the ICU sector that they wanted a tool in the event they had to start making those decisions?
I was aware there were some voices calling for that, including within the BMA as well.
Right, okay, because we've heard from, for example, the Royal College of Anaesthetists and the Faculty of Intensive Medicine saying they felt extremely exposed without such guidance. And indeed, some of our spotlights started developing their own tool in the absence of guidance. All right, so there was clearly a degree of a desire for the tool.
But it would be inaccurate to say that that was a consensus, or indeed, in my view, a majority view. But there were some people calling for it.
All right. I think you said you didn't see it in your statement, but you were aware that it was going to be published.
That's not quite right.
Help us with that then, please.
If I can give a slightly longer answer.
Of course.
It comes back to the exercise we did in the middle of February. When we did that exercise, it was proposed in the meeting that such a piece of guidance should be put together, and I objected. And in the inquiry, Simon Stevens said that I'd called for it and wanted to make the decisions myself, and that was inaccurate and not representative.
Pause.
It's important.
I want to take it slowly to help you.
Okay. So
just pause, Mr. Hancock.
So the first time I came across this concept was in that exercise.
Which was Nimbus.
Nimbus, yeah.
All right.
And in the Nimbus exercise, it was put forward as a proposed solution to there being, you called it saturation, I call it if ICUs were overwhelmed, right? That is it comes back to our previous discussion. And we had a discussion about it, and I concluded then that we shouldn't have such a tool, and that my main conclusion from Nimbus was we must ensure this never happens.
Yes.
Right. Then we go forward 6 weeks or so, and there were calls, public calls. The BMA were in the press. There were private calls for it from, as you say, some of the local areas. And this is an example of the sort of thing I would then talk to people on the ground about. And so I took a wide array of views.
Who did you speak to? Give us some examples.
I remember talking to Chris Whitty about it, but I can't recall exactly who those conversations would have been with.
Can I just ask you, though, Mr. Whitty's not working in ICU.
No, but he has a lot of experience of working in ICUs, and we all knew the pressure that ICUs were under.
All right.
Okay. I may have spoken to some people at the Royal Colleges who I spoke to regularly throughout the pandemic. My view was that these decisions must not be taken by ministers. They are best taken as close to the patient as possible, with as much information about that individual patient, and that doctors make these sorts of decisions all the time. Of course, they were having to make far more of these decisions in the pandemic because of the enormous pressures. And so I knew that with these public calls, I then received this note that's in front of us, and my recollection is that this was the first time such a tool was brought to my attention.
Okay.
And I immediately went to see Chris Whitty, who I knew was sceptical of such a tool. And even though so I was surprised to see that it had been commissioned by the CMOs.
Yeah.
And he agreed that he agreed with me that that it wasn't necessary. And then I phoned up Simon Stevens and I said, I'm really uneasy about this sort of tool. And he said he thought that it was not a good idea either.
Right.
And having spoken to those two people, that's all I needed.
Right.
To make having followed the debate for the previous 6 weeks, and been in my mind throughout that time, I therefore, the system. You can see what happens in government, right? The system effectively got ahead of itself before asking whether this was something that we should consider, and started putting in place, arrange a meeting. That HMIG is a meeting of the healthcare ministerial group on Sunday.
Right.
So they got going.
We're going to come on to that.
And so I just said, I got this. I took advice from those two people and made the decision that it shouldn't happen.
Right.
The other thing that's happening at this point is, of course, this is the worst point in the first phase of the pandemic, because this is when case numbers were really shooting up, and we didn't know if the system was as a whole, as opposed to individual incidents, was going to cope. And frankly, I was petrified that the actions that we were taking in terms of lockdown might not be strong enough to stop the NHS being completely overwhelmed and is getting to the situation, as we'd seen in Lombardy, of a generalised, across-the-board inability to access care. And all the consequences of that.
Right, so just pausing there, just to try and get a sense of why it was you were opposed to it. Is it your evidence that you were opposed to it because you felt there wasn't a need for a national tool, and that actually there should be individual tools taken within trusts or regions?
I felt strongly that if we tried to write a national tool, its local interpretation might end up being too legalistic or box ticking. What I wanted is the doctors to have the discretion to make the decisions as they see fit, with the best way to save lives in the circumstances.
Can I ask you, please, then, about that weekend that you've just alluded to? And can we have a look on screen, please, at INQ 48276/3. And as is the way, Mr. Hancock, with emails, we've got to start towards the back and work our way forwards. But essentially what is going on here, so that you know, is the tool has been drafted. And incidentally, it's in your statement, you said, I didn't see any of the proposed guidance. Is that right or wrong? Did you actually see the guidance that was being proposed?
I don't recall.
All right, okay. It's getting ready for publication, and there is supposed to be a meeting between ministers to discuss the tool, which
No,
didn't
you say-
happen.
Sorry, you say supposed to be. A
Yeah.
meeting had been organised. That doesn't mean there's no value judgment on whether there was a meeting.
All right.
Because if you say supposed to be and then I cancelled that, it implies that was a mistake. It wasn't a mistake.
All right. Let me rephrase it for you then.
Thank you.
There was a plan for a meeting,
Yes.
which then was cancelled.
I cancelled.
All right. I'm just trying to give you a bit of context for where we are to help
Sure,
you when
yeah.
you answer the questions.
Yeah.
All right. So there is the plan for a meeting to discuss with the ministers this tool, and these are some of the discussions about what led to the background, what the strategy is, and what the risks and mitigations are. And it said that lead authors have advised, if we look at the bottom of the page, that most clinicians in acute settings will be receptive to this guidance, as it provides a standardised approach on which to base difficult decisions in unprecedented times. However, it is likely it could be sensationalised by media and cause unnecessary panic and concern among the public. So some competing arguments there about how this may in fact be viewed once it's published.
Yeah.
And then if we go, please, to the page 2 of the document, 30th of March, which I think was a Monday. Sorry, 28th of March, it's my fault, second email down. I've just heard from the CMO's office this isn't going to ministers tomorrow and has been paused for now. I'll make sure the duty team of the current version. And it was because Secretary of State and Simon Stevens have spoken, have cancelled the Ministers' Implementation Group that was there to discuss the tool. This is because they are both unhappy with issuing the tool as it stands, noting how potentially controversial it is, difficult landing. Now, it doesn't say there they're unhappy about it because they think these should be localised decisions, not a national tool. Is it the case that you are more worried about how this might look than whether the profession themselves wanted the tool to provide them with the guidance for the difficult decisions they may have to make?
Oh, I see. No, that wasn't my consideration at all. Obviously, I had to take into account the impact of such a tool on people's confidence in the NHS. My assessment in reading this and the previous page is that it says that most people, most clinicians will be comfortable with, or something like that. I thought that, I'm not sure that's right. There were, as I say, some voices calling for one of these, but that was not a generalised approach. And my assessment is that it is very hard to write something that would improve on an individual clinician making a decision according to the Hippocratic Oath and their best medical assessment of how to save lives. That is, and so I don't, I actually, until I've reread this now, I hadn't really considered the wider controversy as that might happen as critical. The question is, what's the best way to save lives? That was the question I was asking throughout this entire period on every single subject, including this one.
All right. But if you didn't read the guidance itself, how do you know whether it's going to improve or not on the...
Because I had deep experience in government and the consequences of writing guidance, which is to reduce the discretion of those on the front line and to increase a rules-based approach. And I couldn't think, so I thought that the idea of taking these decisions nationally through guidance was wrong. I believe in the principle of subsidiarity for improving the quality of decision making. The closer a decision can be made to those who affect it, generally, the better that decision is.
There's nothing in this email that mentions we need to be actually going this at a local level, is there?
I,
If one follows to the bottom...
there isn't, but I didn't write this email. So this is an email from That's Max Blaine, number 10. He was head of comms. So, of course, the comms people would consider the controversy element of it. This is a communications email. This isn't about the substance of the decision.
The final bullet point on that email says, everyone is clear this needs to be right and not rushed out.
Right.
The CMO's view is that it's not urgent, there's not an urgent need for it right now. And he's told us it didn't come in because as at the 27th of March or 28th of March, there was still capacity in the system. So
And-
that's why, from his perspective, it didn't come in.
Right.
Given there wasn't an urgent need for it right now, did you consider revisiting the need for this guidance at any stage during your tenure?
No, I think it would have been a mistake to bring this in. And I think in a future pandemic, it would be important not to constrain decision makers in this way. We train doctors to an incredibly high standard, including to be able to make decisions like this, and substituting a effectively ministerial decision for a decision of the doctor who is looking after that patient would be, in my view, a mistake.
At any stage did you say to NHS England, for example, I'm not bringing in a national tool, but I would encourage local regions or particular trusts to adopt their own?
No, I think that decisions like this need to be made according to the professional judgment of the clinicians closest to the patient.
Yeah, I understand that.
Yeah.
But, what I'm saying is if your opposition to it was in part that there needs to be local decision-making, did you do anything to encourage or support those that wanted a local decision-making tool?
No, I didn't want a local decision-making tool as in mid-level, as in at a hospital level. I wanted doctors making these decisions,
Right.
not administrators, not ministers. Now, as I've said many times, the operational running of the NHS is for NHS England and the individual hospital trusts. And so I am aware now that some trusts brought in some guidance. I don't think it's right to constrain doctors' ability to act in the best interests of their patients in this way.
All right. Can we look at some of the decisions that were taken to increase capacity within the system? Obviously, firstly, there was the discharge decision, and I'm not asking you about the impact it had on the care sector itself, but did you agree with expedited discharges as a way of increasing hospital bed capacity?
Where that was clinically appropriate, yes.
All right.
But on that, as with other areas, that it really is a question for NHS England.
I was just asking you for a broad overview of
Yeah.
whether you were in agreement with the principal decision, not the detail, all right?
Yeah, remember, hospitals are dangerous places in pandemics. You know, there were more people. The estimate is that more people caught COVID in hospitals than almost any other setting, and that's often forgotten in the debate around this.
We're going to look at nosocomial infection rates a little later, all right?
Yeah.
Okay. There was clearly the decision to suspend non-urgent elective care, and you said, I think at the outset, that was a decision that you agreed with and you thought it was the right decision.
Well, obviously reluctantly, but faced with a series of awful options, that was the least bad. I mean, that applies to almost every decision that we took in the pandemic.
When that decision was taken, I think you were urged to explore with NHS England whether there was any elective work that would be protected at the height of the pandemic.
Yeah.
And what was the answer, and why was it you wanted just to explore that with them at all?
Because I recognised the impact, the negative impact of taking that decision, and I wanted to make sure that it was mitigated as much as possible. But on that, I would very much. It's a classic case where the minister asked questions to ensure that people have considered these things properly, but the operational decisions are for NHS England and the clinical decisions are obviously for the clinical staff.
All right, so as a strategy, you approved of it?
I broadly approved of it, reluctantly, yeah.
No. All right.
Yeah.
For what it's worth, Mr. Hancock, the experts that we've heard about non-COVID care have agreed with the decision in principle. I think it was the right one.
Yeah.
But what they're concerned about is the resumption of non-urgent elective care and how quickly or otherwise that was rolled out, particularly after the first wave.
Oh, yeah, absolutely. Yeah.
All right. Well, you say, oh, yeah, absolutely. Help us then, please. What was your position on how quickly or otherwise non-urgent elective care was resumed?
It was a difficult balancing act, and I relied on the judgment of the Chief Executive of NHS England.
You didn't say, did you say to him, you need to bring in targets to Simon? Did you say anything like that to him, or just, I want you to restart it as soon as you can?
As soon as we safely can. But that's the sort of decision he'd go and take anyway. He was, after all, the independent head of NHS England.
Clearly, you accept, don't you, that the decision to pause elective care had a significant impact on the waiting times for either diagnosis or for treatment?
Yeah, of course. Yeah.
All right. I'd like to ask you about an email that you, I think, were sent. Can we have up on screen INQ 421416_3? We are in March 2020, Mr. Hancock, I think around the 28th or thereabouts. And this is an email that was forwarded on to you, all right?
Right.
It says it's a sad case. This is one of my constituents was due to have a cancer operation at a hospital this week. It's been cancelled due to the issues with coronavirus. He completely understands the pressures on the health service, but he understands if he does not have this operation, he will lose his battle with cancer over the next 12 months. It makes the point that he's 68. He obviously wants to be around for his children, his grandchildren.
Yeah.
He's going backwards and forwards to prepare for the operation. The family are saying online, Boris Johnson said that no emergency operations will be cancelled due to coronavirus, but that's not true. He says, I'm conscious you're up to your eyes in it, but is there anything you, the Secretary of State, or one of the ministers can do? We very much want to help this family. And they were writing to the chief executives too. And if we go, please, to then page 2 of this document. In the middle of the page, sets out that they were clear. I think Simon's probably a reference to Simon Stevens. We're clear no urgent cancer operation should be cancelled. Individual clinicians and patients will discuss what's most appropriate, given the increased risk of infection. And forward on another page, where there's reference to you, at the bottom of the page, you had 3 concerns. Do we need to clarify the position on urgent cancer treatment and other therapies? There have been further 2 cases of people having cancer surgery stopped. While they're not urgent in the sense of days, it probably could not be deferred several weeks. Do we need to issue any further guidance on this?
Yeah.
And then here you are, as at the 30th of March, saying, I'd like to begin thinking about the plan for restarting non-COVID care.
Yeah.
Perhaps Simon Stevens is that, and you
Yeah.
could have an initial discussion at the Quad meeting next week. And then there's risks of people coming into A&E and what that might entail. So this shows that you were clearly concerned from early on in the pandemic, Mr. Hancock, about how best to restart.
Yeah. But also what it shows is I'm asking questions of Simon Stevens and respecting his independence running the NHS.
Yeah. Now, no one's going to criticise you for asking the questions, but it really brings us on to, well, what did you do to make sure that those questions were being answered and that elective care was being resumed?
Yeah.
What did you actually do? What did you actually say to him?
Well, we had, so the Quad, as it's put in here, was the weekly meeting that we had to discuss all NHS matters. I mean, we'd speak on the phone much more regularly than that, but we'd have an overall meeting once a week with Chris Wormald, myself, Simon and Amanda Pritchard. And that was the core decision-making meeting, if you like, when issues were on the boundary between whether they were my responsibility or Simon Stevens' responsibility. And we will have had a series of discussions about the appropriate speed for restarting given the wider pandemic. And my concern throughout this was that the NHS needed to ensure it took full accountability for nosocomial infection. And as you'll know, I had a series of meetings about nosocomial infection specifically as well. And also that there was the danger to people of catching COVID whilst in hospital for non-elective care. But at the same time, though obviously we did need to restart as soon as that was safe to do so. But for the individual decisions, they're a matter for Simon Stevens, so you have to ask him about them.
I'm not asking about the individual decisions. It's just a global question. There is no doubt, though, if one looks at some of the data, in fact, the UK was very slow to restart its elective care in a way that affected the figures that we've seen. I want to just ask you about HIPS in particular. Can we have on screen INQ 474262? Because this is a excerpt from the _61, please. This is an extract from the HIP experts that the inquiry has heard from.
Yeah.
And essentially what I'm going to show you is a graph that shows that UK fared much worse than Europe, where there was a drop in hip replacements, understandably everywhere, but 14% in Europe, and yet 46% in the UK. And could we have a look at the graph, please, on page 62? And could we highlight the top graph, if you're able? Can we see that? So there's obviously a pausing of elective care across Europe, but a wide variation in how the UK has performed, and essentially we've done badly because there's 6% drop in the number of cases of people having a hip replacement, whereas the average across the EU was 14%. Now, were you sort of ever made aware of, perhaps not hips in particular, but the kind of delays and, on the face of it, slowness at the resumption of non-urgent elective care?
I was.
And what did you do about it?
Well, I spoke to Simon Stevens about it, and you'll have to ask him about the individual decision. I don't mean the individual decisions as in each hip at a time, about the policy towards restarting, because that was very clearly in his bailiwick.
I understand that, but Mr. Hancock, you're the one early on in the pandemic is saying we've got to have a plan for resuming elective care.
Yeah.
You're onto this early, if I can put it like that. Let me finish. You're onto this early, but when we look at the data, perhaps your desire to resume it did not in fact pan out with what happened on the ground. And why is there, if the minister is saying, get started, get restarted, why are we seeing such poor figures like the one I've just shown you?
I'm afraid all I can answer is that these decisions on the restart were decisions for NHS England, and this is a module about the performance of the NHS, so you have to ask the person who's in charge of the NHS at the time.
All right, but you're not powerless. If you say to him, do something,
you can see
he doesn't ignore you.
Yeah, exactly. You can see in the paperwork that I'm pushing on this subject, but when the NHS was legally independent, I in fact ended that legal independence. You know, Simon and I worked very closely together, but some decisions were his and others were mine. So this isn't something that I've seen before, and it isn't a decision that I would have myself taken.
All right. Do you think, let me broaden the question then, do you think in the event of a future pandemic there need to be contingency plans at either ministerial or certainly department level for a strategy for how to, if not continue it, at least resume it quickly?
Well, I think, yes, and actually that needs to be a part of a broader change in the NHS to try as much as possible to separate out urgent care and elective care into different settings. And I know that's something that Simon Stevens believed very strongly and was working on even before we went into the pandemic. But that so-called split between hot and cold sites is very effective and a much more normal arrangement in other European countries. So that may be part of the explanation here, but I can't really give you any more than that because this wasn't my area of responsibility.
All right, fine. And were you aware, as Minister, of the use of elective hubs to ensure that there was some diagnosis or treatment for non-pandemic conditions?
Yes, of course.
All right. Do you think there was sufficient use made of them?
Definitely not.
All right. And how do you think we could improve use of elective hubs?
Have more of them.
Have more of them?
Definitely. Should be happening now. Yeah.
And is that a decision for the NHS, for NHS England, or is that something that ministers can assist with?
Well, now, because we changed the law so that the NHS is not statutorily independent. It is something that ministers can do, but it wasn't at the time directly.
Different measure of increasing capacity is nightingales. And I think you say in your statement that you are supportive of them. You thought it was important to have them if we needed them.
Yes.
All right. Given that we, as looked at this morning, there were already stretched ratios within ICU in hospitals.
Yes.
What was the plan for further stretching the staffing in the event that we had, I think, 7 nightingales in England?
The plan was to build the Nightingales within the umbrella of an existing trust so that the Nightingale hospitals did not have to set up HR and recruitment systems from scratch, but rather could be supported by an existing trust. For instance, the Nightingale Hospital in the Excel Centre in London was effectively run by Barts Hospital.
Yeah. So was it your understanding that there would be additional staff, or that the 1-to-6 ratio would include staff that you'd lost from the hospital who'd gone to staff the Nightingale?
Well, the answer is it isn't binary. We were at the same time trying to recruit more staff back into the NHS, but the starting point was that that hospital trust was responsible for the staffing of the Nightingale, and we were doing everything we could to ensure that that and all hospital trusts could get more staff as well as stretch the ratios.
All right. Do I take it that you consider, Mr. Hancock, that there was a need to have the Nightingales just in case we needed them?
No, we needed the Nightingales in order to provide the care for those who went into them.
Yeah.
Hundreds of people received care in Nightingale hospitals and survived because of it. Of course, the Nightingales were also entirely justified on an insurance policy,
Yeah.
right? Because we didn't know when the pressures were going to stop accelerating. And in the event, several of the Nightingales weren't used, but even those, I think we can justify with what we knew at the time.
Okay. Pause there, because I'd like to just look, please, at INQ 474444, which might help you, Mr. Hancock, because it's a quick and easy guide to when the Nightingales were set up, what activity they saw in each wave,
Yeah.
and the costs of them for what it is worth.
Yeah.
And we can see that, yes, there were hundreds, but it's not thousands of people that was going into the hospitals to being treated for COVID.
Yeah.
Obviously, some of them were repurposed.
Yeah.
But if you look at Birmingham, for example, it had no patients admitted in wave 1 or wave 2 and wasn't used as a vaccination centre or to resume elective care.
Yeah.
The question is really, once we thankfully didn't need them in wave 1,
Yeah.
what, if any, involvement did you have in how they were being repurposed for wave 2?
Well, I was. I have two feelings in response to this. The one is that I have absolutely no doubt that they were justified, even as an insurance policy, and even if no lives had been saved by them, we didn't know when I commissioned them. Well, I commissioned the expansion. It was actually Amanda Pritchard who came up with the idea of using existing buildings to put hospitals in and led the project and did a brilliant job at it. So I think they are entirely justifiable because they were an insurance policy in case we hadn't managed to turn the curve of the growth of the virus when we had. At the other end, I also felt frustration at the time that they weren't being used for other purposes. But that happens all the time when you're health secretary because you're responsible for a large body which is statutorily independent from you and is huge. And so all sorts of stuff goes on in the health service that you would rather were done better. And your job is to try to make that happen either through specific intervention, persuasion, or through changing policy at a national level. But I didn't want to change policy because I wanted the Nightingales to be there if they were
if they were needed.
Yeah.
Right, I understand that, but what I want to know is what did you do to ensure that in wave 2 they were utilised to their best effect, particularly when we've got, for example, Birmingham admitting no one and seemingly doing nothing?
Yeah, well, I will have raised this, it's probably in quad minutes, I will have raised this with the NHS, but obviously operational matters are for them.
No, I follow that, but didn't you say to them, well, hold on, you've got a big
Yeah, it's
facility there in Birmingham that's not doing anything. Can we repurpose it? Can we use it?
That's exactly the sort of thing I would have said, yes.
You would have said or did say?
You're asking me for a recollection of something 4 years ago. I'm pretty sure that I said it. The place to look would be the minutes of the quad meetings.
Do you think, and I'm asked to ask you this, given the expenditure, which in England alone was 358 plus million, that this was a good use of resources, diverting money that could have been used to improve the NHS estate, for example, more portable ventilation and the like?
That is not an accurate description of the trade-off.
Right.
The trade-off was, should we spend taxpayers' money that was effectively borrowed from future generations for this insurance policy? At this point, the constraint on the NHS was not cash resources, it was real-world resources. And so, yes, I thought it was a good use of money to have this insurance policy.
Thank you. I think you are aware that between waves 1 and wave 2, NHS England, supported by the Department of Health, asked for funding for a further 10,000 beds.
Yes. Am I aware? I was deeply involved in this bit, yeah.
Hold your horses, all right? Let me just ask the question and then you can answer, all right? You were aware that there was the request by NHS England and the department. You just told us you were deeply involved in it, all right? Unfortunately, though, that request was refused by the Treasury, and there was a direction or a steer coming from the Prime Minister that you should focus on using the Nightingales, using the private sector, hopefully discharging more people. Maybe they're not being using the flu vaccination to prevent flu patients going into the hospital. Help us with the deep involvement that you say you had in this, and what did you try and do to either get the beds or get the funding?
Well, there were a significant number of meetings in Number 10 over that summer to work out how we were going to handle the winter of 2020 to 2021. Yeah. One of the things that I did get over the line and get the funding for was an expansion of all of the A&Es in the country, in England. And because I was only responsible for the NHS in England. And in addition to that expansion of A&Es, I wanted an expansion of bed capacity. Yeah, for two reasons. The first is, in case there was a second wave in the winter, which started to become evident from late July onwards. And the second is because I think that the resilience of the NHS to future pandemics requires more beds. And that you never put the entire army in the field in one go. You have resilience. And in the same way, having resilience rather than running at 100% all the time in our health system is an appropriate use of national resources. Is what we ought to do. So I raised it with the Prime Minister. I raised it with the Treasury. I will have done that in formal and informal settings. I raised it with the Cabinet Secretary, and you can see that I did that verbally and in messages. I internally campaigned for this extra funding, and as I say, I won on some counts, and I didn't win on this one.
All right. What do you think were the consequences of the refusal for the 10,000 beds from your perspective?
The pressures on the NHS were greater in the second wave than they would have been otherwise.
Yeah. By the time you left office, had you taken any steps or made any requests to ask HMT for them funding for the 10,000 beds? It had been a very... I'd lost that battle. It was a clear no in the summer of 2020. When I left office, we were starting to gear up for a spending review, but I wasn't engaged in. I mean, we were starting to think about it, but it was not in advanced stage of discussion. Okay. You start basically the NHS, and at a policy level, we start preparing for winter in July. Yeah. All right.
On the basis that you had the Nightingale hospitals and some, like Birmingham, weren't used at all, how did you justify the application for 10,000 more beds from the Treasury?
Because I was very worried about a second wave, and I was worried about political opposition to a second wave being harder than first time round. And the history of pandemics is that the second wave tends to be bigger than the first. That is not just that is not just what happened in the UK in the COVID pandemic, and that's because of it being essentially sociologically across society harder to win the argument for the action that's needed second time round, and that's exactly what happened.
Now, as a minister, you're used to dealing with the Treasury, and that you have to justify your case for increased funding.
Yeah.
With good arguments. How are you going to meet the argument? But we've already funded Nightingale hospitals, and they're not being used. How did you plan to meet that argument?
Because we needed overall long-term resilience in the NHS.
Oh, this was 10,000 beds generally?
Permanently.
Oh, I see. I'm sorry.
Yeah. Get them in place for that winter and keep them there in case.
No, I understand. Thank you.
Can I move on to a different way of increasing capacity, which was the use of the private sector?
Yeah.
And in your statement, perhaps if we could have up on screen 42858_20, which sets out the use that was made of the private sector, or independent sector, as you call it in your statement, between March and May 2020.
Yeah.
We can see there, paragraph, excuse me, 78, over 7,000, approximately, I should say, 7,300 non-elective admissions, over 111,000 outpatient attendances, over 4,300 ordinary elective admissions, 12,900 day cases, and over 19,000 diagnostic imaging tests and chemotherapy treatments. The money spent on the private sector, you say you consider to be value for money.
Yeah.
Just help us understand your role in either approving the funding or monitoring what use was made of the funds.
So I didn't have a very significant direct role in this at all. I supported the use and the commissioning of the private hospitals. I asked the department for an assessment that we were getting decent value for money, and I got that assurance, I think, from David Williams, and my junior minister, Ed Argar, signed off ministerially on these, but they were negotiated by Simon Stevens.
All right, okay. And one other measure to try and help the predicted influx of patients into hospitals was use of NHS 111, wasn't it? Is it correct that by January 2020 you wanted NHS 111 to be the single point of contact?
I wanted it to be available as a first point of contact.
Yeah. Well, in fact, we know that from, I think, mid-March, the public were urged to use 111 as the first port of call, if I can put it like that.
Yeah.
Given that that was a clear way of helping to triage patients
Yeah.
and not sending patients to hospital that didn't need to be there, what steps did you take to monitor the efficacy of NHS 111?
So I had regular briefings on 111. There was a stage when it was under deep pressure.
Yeah.
And the reason for that pressure is that at the meeting to decide on bringing in lockdown, Simon Stevens pointed out that if we bring in a lockdown measure and say, if in doubt, called 111, that will lead to enormous pressures on 111, and asked in the meeting for a short delay in the bringing in of the lockdown measures by, I can't remember, 24 or 48 hours, in order to spend that time urgently expanding the capacity of 111 and getting them prepared with scripts and what have you. Essentially operational requirements. The Prime Minister, based on the urging of the Mayor of London, who was, and most of the case, the biggest intensity of the virus was in London at that point, decided to bring in the measures immediately, as of midnight that night.
Right.
I think that was an entirely, either decision would have been entirely reasonable. It was, with hindsight, probably better to take the decision that the Prime Minister did take because we needed to stop the spread of the virus. But it had this operational consequence that 111 was under deep pressure for several weeks, a few days of exceptional pressure, and then and whilst they got more people in and the demand
All right,
substituted.
well, let's look at that exceptional pressure. Can I have up on screen, please, 474-285_17? This is an extract from the expert report of Professor Snooks, who looked at the pressures on 999, 111 services, a number of other pre-hospital.
Yeah.
Goes. But in short, once it, excuse me, once it comes up on screen. (474-285_17). And if it doesn't work, I'll do it another way, Mr. Hancock, all right? It's okay. This shows us a sort of a broader view of number of calls to NHS 111
Yeah.
that either answered within 60 seconds, abandoned after at least 30 seconds, and the calls answered over 60 seconds. But can I just help you to this extent? In January 2020, 111 calls were at 1.5 million. In March, that rose to just over 2.5 million, all right? But in March 2020, 1.1 million of those calls were abandoned and went unanswered. Now, it may well be that some of those people rang back, but there was a significant number of people abandoning calls to 111. And clearly the level of demand substantially higher than was predicted and was not matched by the capacity of the 111 system. Now, were you aware of the significant number of abandoned calls in March 2020?
I was aware that 111 was under pressure. If I may say, if I'd received this at the time, I would have said that I don't think calls abandoned after 30 seconds is a good metric.
No.
Because if people call 111 to find out something that is not clinically urgent, if you like, and abandon their call after 31 seconds, then they either might have found that information on the website or found it somewhere else or didn't really care deeply about that call. Calls abandoned after a longer period would be a more appropriate metric. So, yes, there's pressures, but I'm not sure this is the best way of describing them.
All right. Put aside that on any view, there are a large number of calls that are abandoned within that month, and a large
also
number
a
of calls.
delay in how long people took to get that response. Yeah.
Yeah, but take it a wider perspective.
Yeah.
The point I was asking you is if you ask the public to ring 111 as their first port of call, isn't it incumbent that you can staff and properly resource that call centre?
In a pandemic, sometimes you have to make difficult decisions between impalatable options, and the Prime Minister made the decision to bring in the lockdown immediately, which led to these pressures being as urgent, as acute as they were, rather than leaving 24, 48 hours to get 111 up and running. In a perfect world, you wouldn't have pandemics, and we were in a pandemic. So that was another example of two unpalatable choices. And I think that, with hindsight, having reflected on this question, I think the Prime Minister made the least bad choice.
There were clearly, though, concerns in your mind about strengthening 111, because in May of 2020, you asked that question at a Quad meeting. What can we do to really strengthen 111 so it becomes the first port of call instead of A&E?
Yeah.
What were you being told in May that provoked you asking such a question?
Well, this was, by May, the acute problems in 111 had been mitigated, and the NHS had expanded capacity, and the system was running well. This isn't about what I was being told. This is about the action I was trying to take. At my instigation, I wanted us to bring in a system of 111 first. And the idea there is that before going to A&E, you call 111. And if you can be dealt with on the phone, you are. And personally, I think it should be our national system and normal, if you like, and every citizen know that if you're going to go to A&E before going to A&E, you call 111. And that be a sort of a process, both so that A&E knows better what's about to come through its door, so for sort of operational reasons within an A&E, and also because a whole load of cases might be able to be solved on the phone or triaged to a non-acute setting. So I think we should bring that in anyway. I tried to bring it in over that summer. It was a major operational change.
Pause, I'm going to ask you about it.
Okay.
All right,
But that's what that was all about.
Right, okay, so let's go to May 2020. To help you, Mr. Hancock, can I have on screen INQ 409864? Because there was a meeting about non-COVID A&E and NHS 111 on the 22nd of May, all right? And you were updated on the figures for A&E. Attendance had dropped by more than 30%, but had begun to rise, all right? And then NHS 111 during the crisis, this shows calls through to the 111 service very steeply in early March, as we just looked at. Capacity couldn't increase at the same rate, so at a peak, 40% of calls were not answered. Later in March, there was a reduction in capacity while increased activity was maintained, and there was a particular spike when you offered testing to symptomatic people through 111. By May, activity levels are now much more in line with historic levels, and we're now answering the vast majority of calls. Bottom bullet point, please. Secretary of State noticed he was surprised that with the sharp fall off in A&E, NHS 111 is not picking up more of the burden, at least by the telephone service. He asked where that demand has gone. It was noted that lockdown means fewer patients of other types coming in, people who've got injuries and the like. This means there's missing demand somewhere in the system. Obviously you were concerned that if people aren't going to A&E and they're not ringing 111, but they're still getting injured or still need treatment, where are they going? Is that the missing demand that you were worried about?
Yes.
All right. And what did you do about the missing demand?
Well, the note itself gives some explanations for why there might be less demand. There are less, sports matches in a pandemic, and therefore there'll be fewer injuries, and there's the number of non-COVID infectious diseases, actually, we didn't know this at the time, but fell very, very sharply during the pandemic because of social distancing. So that is a reasonable answer. And I had a meeting on non-COVID A&E regularly. So I would have, if you say, what did I do in the future? I've asked about it here, and I imagine I would have followed up in future meetings, but I can't remember exactly.
The Health and Safety Investigation Branch have prepared a report in relation to 111, and they concluded this: there was strong messaging around patients staying at home if they reached a self-care at home disposition. For some callers, though, this had discouraged them, that messaging, from recontacting NHS 111 or seeking medical advice from elsewhere, even if their condition deteriorated. Were you aware that there was some people that were actively not contacting NHS 111 and or not going on to seek medical advice from elsewhere? Yes,
and I was talking about this publicly at the time. It comes back to the point I was making in the first session on reassuring people that the NHS was available and open and not overwhelmed. It's all part of the same. It's all part of the same piece.
All right. Well, let me ask you about that now. Then, in hindsight, do you think the government and/or your department took sufficient action to encourage those who needed healthcare to come forward?
We encouraged people from pretty early on to make clear that the NHS was still available if it was needed. It was a very difficult balancing act, those communications.
Follow that, and you're not the only witness to have given that answer, Mr. Hancock. But
it's my experience of it.
I know, but what I want to go is what do we do different next time to
Sure.
help encourage people to come forward where they may have to stay home because there has to be a lockdown?
We need to make sure that that is a clear part of communications throughout, I think, and that's what we did. The challenge is in communication, communicating more than one message at once is always very difficult. This was a two-part message, which is stay at home, brackets, unless you really need the NHS, in which case please do go.
You mentioned NHS 111 first, and could we just have back up on screen, please, 409-864 _ page 2. There's a bullet point missing at the top which says NHS 111 first. Don't worry about that. But you mentioned there's a real risk, the level of demand on A&E from self-presenting causing crowding, and you need to prevent and there's a need to prevent social distancing in a core health setting. We need to triage through 111 before self-presenting. So you don't want A&E bursting at the seams, effectively. Is that what you're saying?
Correct.
All right.
Yes.
And your overriding steer, a number of bullet points down, is to bring in NHS 111 first, which was essentially is it a booking system, as I understand it?
Well, to the extent that you could use it as a booking system, I think that that's what we should have. But of course, sometimes you've still got to turn up at 8.
Yeah, no, sure. But wasn't the plan there for there to be a booking system
Yes.
so that not everyone turned up at 9 a.m., but
Yeah.
you separated them out through the day to help the hospital, help maintain social distancing, help prevent the spread of infection?
So you wouldn't want a booking system to be universal. You'd want it to be a contributor, i.e. if somebody has a problem that requires treatment, but the assessment by 111 is this could wait an hour and the A&E is very, very busy, you might say, please come in an hour's time and book in a slot. But you'd also obviously want the ability for 111 to say, this sounds urgent, get yourself to the nearest A&E without having to go through the rigmarole of a booking procedure. So long as it isn't required to book, but is an available facility to book, I think 111 first should be both in a pandemic and in normal times, the way that we access the NHS.
So here's you talking about the rollout of NHS 111 in May.
Yeah.
In fact, you announced it in September, and the plan was to roll it out from December.
Yeah.
Can you help us with why it took from a sensible plan in May to not being rolled out for many, many months?
The operational reasons you'll have to ask the NHS. My recollection is it is essentially about upgrading NHS computer systems to allow this to happen. And anybody who knows anything about NHS computer systems knows that they are in dire need of improvement, and things like this take time.
All right. Ambulances, please. We have heard inevitably about increases in both the number of calls and the waits people had to endure before an ambulance was available to get them. And can I ask you, please, about some of the things that people told the inquiries Every Story Matters record? Because we have on screen, please, INQ 474233 _ 110. Thank you very much. And can you see in the middle of the page, Mr. Hancock, patients shared many experiences of them or a loved one being very unwell, calling their GP 111 or 999, but facing delays or not receiving care. Some contributors either gave up or had to wait until their symptoms had become very severe before trying again. There were similar experiences amongst those who had suspected or confirmed COVID and those who had other urgent medical problems. And we can see a quote there from one of the contributors. One night I was sick over and over again. At 1 a.m. I called 999 and they said they would send an ambulance. By 6 a.m. it still not arrived. I got back into bed, pregnant and exhausted. At 11 someone phoned to ask if I still needed the ambulance, said that other cases were more urgent. They advised me to contact my GP. I did, and the GP refused to see me, saying I should contact 999. At this point I gave up. There was no help. That's just one quote of a number of people. About 30,000 people contributed to the Every Story Matters record. I'm not saying they all made reference to ambulance problems, but were you made aware of the intense pressures there were on the 999 system and the length of delays that some people were experiencing?
Yes, and again, I visited ambulance stations throughout the pandemic. In fact, one of my very first visits was to an ambulance station, and I remember meeting the man who was responsible for coordinating sending out of ambulances, and he burst into tears on me. It was incredibly difficult for him because the pressures and the number of calls, and they hadn't seen anything like it before.
I think you were aware there was a shortage of drivers amongst the
Yes.
in the ambulance
Yeah, there was. Yeah.
sector. Can you think of any practical way of resolving a shortage in a short term in the event that we need to upscale the sheer
Yeah.
number of people that can drive an ambulance?
Well, one example may be that we should have people who are trained as ambulance drivers on a standby, a bit like we have the Territorial Army.
Yeah. Was there any plans in place by the time you left office to have such a reserve?
Well, knowing the pressures first time round, I think my recollection is that in the second peak, whilst there were still enormous pressures on ambulances, they were not as acute. And again, I visited ambulance stations and talked to the ambulance service about this, and I talked to individual ambulance drivers and paramedics in order to get a sense of it from the ground up as well. So my recollection is that second time round, the ambulance service was able to withstand those pressures better, and I'm sure that I'm sure there's lessons that can and should be learned, and the two waves compared and contrasted against each other. But obviously, the running of the ambulance service itself it was for the NHS at an operational level.
All right. Finally, on ambulances, please. Delays are sadly nothing new in handover times from, we're all familiar with ambulances being stacked up outside A&E departments and the like.
Yeah.
Do I take it you would agree that the pandemic made an existing problem worse?
Yes, absolutely, yeah.
We have heard evidence that it was not uncommon for patients to be held in an ambulance for 6 to 12 hours. Were you getting reports of that kind of length of delay before the patient could actually be taken into the emergency department?
And not only did I get those reports, but also I knew of hospitals where the delays were much, much shorter, and it was deeply frustrating that at some settings they organisationally managed to get this sorted, and at others the ambulances were unavailable because they were parked on the ramp for 6 hours or 12 hours, as you say. And that was obviously deeply frustrating.
All right, can I ask you about that frustration? Because then you've got an inconsistent picture. Some places not doing so badly, some places doing really badly. When you as Minister hear of reports like that, what do you actually do to say, oh, come on, guys, how come one part of the country is doing well and another part's not?
Well, this is a perennial problem across different parts of the operation of the NHS. This is primarily a matter for the NHS themselves. In this instance, I had a series of meetings with Pauline Phillip, a very impressive NHS senior manager who'd run hospitals incredibly effectively, was then brought to the national level to try to tackle these inequalities of service. I mean, this is a problem in normal times, then exacerbated in the pandemic, both by a combination of the pressures, but also the fact that the pressures themselves were differentiated across the country.
Were you made aware of concerns amongst ambulance staff about the fact that they were in the back of an ambulance cab, often in very close proximity to a potentially COVID-positive patient, with inappropriate PPE?
I was absolutely aware of the problems of getting PPE to ambulance staff, and I remember one person who was responsible for getting PPE to a particular ambulance hub, talking to him on one of my visits, and him saying, I've got to protect my team, and so getting the PPE out to all the individual locations was a massive logistical problem.
Yeah. All right, we're going to come on to the PPE. Just finally, please, before we finish this topic, clearly delays waiting to get into emergency departments, And then were you aware of the delays once in the emergency department, with patients waiting up to 12 hours or more before a decision to admit them was taken?
Yes, I mean, that was a problem before the pandemic, let alone during it.
The Royal College of Emergency Medicine have carried out a report into the impact of delays in emergency departments. They did some modelling, and it showed that in 2021, of those who waited 8 to 12 hours in an emergency department, there were 4,519 excess deaths in England associated with long waiting times in emergency departments. What, if any, steps did you take to try and resolve the logjam of people going off the ambulance into emergency departments and then into the hospital if they needed that care?
Well, again, this was a frequent subject discussed between me and Simon Stevens, who was responsible for this. The challenge, responsible as in it was his, he was responsible for this policy area. It wasn't his fault. The challenge of how to unblock emergency departments is a significant one. Many improvements have been made. One of the examples of things I did was got the money from the Treasury to expand all of the emergency departments during this period to make sure there was physical space. But actually, one of the biggest barriers to flow into emergency departments is flow out of emergency departments into the hospital proper. And that, of course, was also, that in turn was, is a question of getting the appropriate discharge at the other end. So you can't see the hospital in isolation from the call handling system, whether it's 999, 111, through to A&E, through to the admitted element part of the hospital, through to discharge and social care. It's one system, and if you've got a blockage in one part of the system, it bungs up every other part of the system. So you can't look at this in isolation from the challenges of discharge into social care, which is why Simon was so keen to ensure that we had discharge from hospital into social care and pushed so hard for that policy, because he was responsible for ensuring that when the ambulances turned up at A&E, people could get off the ambulance into A&E, and the only way to make enough space there was to make sure people could get from the A&E department into the hospital proper.
Mr. Hancock, I want to change topic completely and just deal with a couple of discrete topics before we take our lunch break, and then we're going to come to some bigger topics.
Okay.
All right. Can I ask you, please, about DNA CPRs? And you did, in fact, refer to DNR orders earlier this morning. Yeah. I think were you made aware of concerns that blanket or inappropriate DNA CPRs were being imposed? And if so, what did you do about those concerns?
Yes, I was made aware of concerns about inappropriate use of do not recover notices. There were reports in the press as well, and I thought that this was appalling. The principle of healthcare has to be based on consent, and any DNR notice without appropriate consent is wrong and potentially illegal. So yes, I heard these concerns directly from families, and I heard them through a number of different routes. I mean, put yourself in the shoes of the family whose loved one has not been resuscitated because somebody has said that they shouldn't be, without either that person or the family being asked. It's appalling and totally unacceptable. So the steps I took was to make clear publicly, as soon as I heard about it, that this was completely unacceptable, and we reiterated and made clearer, as far as I can remember, the guidance around it. But it was something that I had to get involved in, even though it's technically a matter for the NHS, because one of the tools I had during the pandemic was to communicate directly to NHS teams on the ground through the press conferences, and this is one example where I used the press conferences not so much to communicate to the public, important as that was, but to communicate to NHS staff that this mustn't happen.
All right. You said do not recover. Did you mean do not resuscitate?
I do.
All right, it's fine. I just want to be clear about the language in this area. You said there that you heard directly from some of the families involved In what fora did you...
My recollection is hearing through an MP, and that of this happening in the Brighton area. So that's my recollection, but we'd have to look at the paperwork.
You say in your statement at paragraph 107 that on the 10th of April of 2020, you attended a meeting, in fact, with officials to discuss the adult social care plan, but DNA CPRs came up in the course of that meeting. And your private secretary's note of the meeting says you commented that the DNR discussion needs to note that for many people, not going to hospital is the best decision, but this must be a sensitive clinical decision based on individual needs and circumstances. Not going to hospital is not the same thing as not being resuscitated. Were you clear in your mind that a DNA CPR was only there to prevent cardiopulmonary resuscitation and was not to be treated as a do not treat order?
Absolutely.
All right. My lady, it's a little early, but would that be a convenient moment?
Certainly, I shall return, provided it's slightly warmer where I'm sitting, at 22 to 2.
Thank you very much.